All right, as everybody is filing in, welcome to the PQC Education webinar series. Today's webinar, we are going to hear about listening to providers and learning from data, advancing perinatal SUD care and reducing accidental overdose fatality. And our presenters today are Presley Azarkan, a resident here at UVM-MC, as well as Jasmine Bazinet Phillips, who is the Dean's Medical Student Research Fellow. And before I turn it over to them for today's lecture, I'm going to have next slide. We'll go over a little bit of housekeeping. Um, So today we ask that you all use the chat box to type in your question. I will be monitoring the chat today. We also, you all should be muted upon entry, but if you would like to ask your question verbally, you are more than welcome to unmute and ask that. We also have the automatic captioning. So if you go and find the show captions in your navigation bar, you can find those automated captions. And finally, before leaving the event, we will be asking you all to fill out an evaluation. I'll put that link in the chat at the end. And next slide. Oh, yes. And so we have our acknowledgement. So this webinar is partially funded by our AIM grant. And so it's supported from HRSA. And as such, please know that the contents of this webinar is that of the authors and not necessarily a official representation of HRSA, HHS, or the US government. And next. And no disclosures. Okay, and then I'm gonna turn it over to Presley and Jasmine.
Great. Thanks so much, Sam, for the intro. And thanks everyone for joining us today and having us come and chat. As Sam mentioned, I'm Presley and I'm presenting alongside Jasmine. Today, we're going to be talking about how we can advance care for perinatal patients with substance use disorder. Kind of our big goal and some of the research that Jasmine and I have been doing from the past year has been to bring together kind of two key perspectives and combine what we're seeing in the data through a quantitative research review with what providers are experiencing kind of in their real world practice. And our hope is to better understand kind of where gaps exist and where there's opportunities for intervention and ultimately reduce overdose risk in our perinatal patients. So this is kind of just a quick outline of where we'll go. I'll go through some background and some context and then move through our quantitative findings, kind of looking at postpartum medication for opioid use disorder continuation. And then we'll shift to Jasmine after that to look into some of the qualitative insights from providers across Vermont. And then we'll close kind of by bringing together a discussion of some of the key gaps and some of the opportunities that there might be for some system level changes. Okay, so just before we begin, there's a few definitions and kind of phrases that I'm sure a lot of folks are familiar with, but we just wanted to make sure we started on the same page. We'll be talking about integrated care models and separate care models. These are kind of two different forms of providing medication for opioid use disorder care for prenatal patients. Integrated care, people will receive their prenatal care and their MOUD management by a single provider. So that's often obstetricians or also family med providers versus separate care where the prenatal care is provided with a different provider providing the MOUD care. As listed here, also, we will use the terms medication for opioid use disorder or MOUD, and then OUD as opioid use disorder. And then you'll also see social determinants of health, abbreviated SDOH. So in terms of some of the background and kind of why Jasmine and I really wanted to focus in on this, is looking at the data from the past 12 years in Vermont. This figure is from the Maternal Mortality Review Panel report, which shows the maternal mortality in Vermont by cause over the past 12 years. As you can see on the top row, what's particularly striking is that accidental overdose is one of the leading causes of maternal death. This coincides with what we're seeing on a nationwide level, as this has also become nationally the leading cause of maternal death. So this is super important for a lot of reasons. First, it highlights that substance use disorder is not just a peripheral issue, it's really central to our maternal health outcomes, especially here in Vermont. And then secondly, something to note is that this is something that can be largely preventable. We see a lot of other maternal deaths that we've really focused on through things like our AIM goals, but this is something that, especially in states like Vermont, we have a lot of area to really address substance use disorder, and it's really critical in improving our maternal outcomes. So this is just a timeline kind of going through the past 20 plus years of what opioid use disorder and treatments for it have looked like in the state of Vermont. We're really actually quite a front runner in developing a lot of systems to address this issue. Back in 2002, the very first methadone clinic was established. And you might be familiar with the term COGS. This has actually become kind of the resident run OBGYN practice out of UVM, but it was actually kind of the first methadone clinic to treat patients, particularly perinatal patients with opioid use disorder. We've come a really long way throughout this time with a lot of steady expansions in services, as you can see, from the launch of the Care Alliance to models with multidisciplinary care like CHARM and ICONS. We've added a lot of different policy changes like the elimination of the X waiver. So all of these things have really further expanded access to treatment. I think the biggest thing that we'll touch on today is before just around 2022, then we started to really implement the hub and spoke model. And this is something that has really expanded our access, especially in our rural state of Vermont, to opioid use care. And has really kind of provided a strong infrastructure and definitely a big change from when we were only providing opioid use disorder care from a single clinic through COGS to now having a lot of different locations throughout the entire state. Um, for the next slide, specifically in terms of the hub and spoke model, for those that are not familiar, this is a model that's really central to delivering medication for opioid use disorder. In our rural state of Vermont, there are hubs throughout the state that provide higher intensity treatment. This includes methadone initiation and specialty addiction care, typically at these regional centers. And then there's spokes throughout the states that, on the other hand, are providing more of the maintenance treatment in community settings. These are for patients who are more stable on their medication and really has helped to improve accessibility, especially kind of from a geographic standpoint, and reduce a lot of those transportation barriers for patients by being able to provide in a community setting that's much closer to home. So these models have been huge in expanding access to medication for opioid use disorder, but they have definitely introduced some changes and some complexity in how we apply this to our prenatal and perinatal patients. It, by and large, has allowed for increased access, but just kind of brings up some points in terms of improving transition points, especially kind of in some of these vulnerable perinatal settings. So that's kind of the background. Oh, this is just a map of where these hub and spoke models locations are at. The left is the hubs and the right is the spokes. Um, so with all of this together, Jasmine and I really wanted to kind of understand where we're at in the realm of all these changes over the past 20 years and kind of where we can go from there. So we designed a mixed methods study to look at this and to kind of better understand some of these issues. The quantitative component focuses more on some of the measurable outcomes, things like MOUD continuation and some of the healthcare engagement, whereas the qualitative research aspect explored more of the provider experiences, what challenges they're facing, what works well, and where some of the systems have broken down. So combining these approaches, we are hoping to kind of move beyond just describing what this problem is and really understand some of the mechanisms specific to Vermont that can kind of help to improve our care. So I'll speak first about the quantitative research review, and I'll turn it over to Jasmine for some of the qualitative research. So, from a methods aspect from the quantitative research review, we were first trying to look kind of at factors that are associated with this postpartum continuation of MOUD. We know this is a highly vulnerable period for patients, and we are seeing a lot of these maternal deaths happening in the postpartum period, which is kind of what focused the initial review on the postpartum timeline. We conducted a retrospective cohort study using an EPIC chart review. We looked at patients that received MOUD in the third trimester of their pregnancy. We initially were looking at deliveries between 2021 and 2023, but hoping to eventually expand that to include more recent years as well. We followed them through their full 12-month postpartum. And all these deliveries were occurring at UVMC. Likewise, we hope to expand to kind of look at other locations as well, Porter and CVMC, and then potentially even beyond that into some of our community sites. In terms of some of the basic results for this, we had 175 deliveries during that time frame. At 1 year postpartum, only about half of patients had their MOUD status documented in the medical record. Of those, it was a pretty high amount that did continue treatment. So 79%, we could see continuation of treatment through the full year postpartum. So at first glance, this looks relatively strong, but really that's just among that small, only half of the subset that we were able to see. So this was pretty early on that we found this data, and it was quite striking that we could only really tell about half of what our patients were doing in the first year postpartum. So running into this major issue, with our original goal being to identify factors associated with postpartum discontinuation, we essentially had to kind of regroup and realize that we couldn't really reliably answer this question when we were missing data for nearly half of our patients. We simply didn't know what happened to them after delivery. So we took a pretty big step back at that point, and instead of asking who's discontinuing their medication for opioid use disorder after delivery, we asked instead kind of why can't we even see what's happening to these patients in the first place? And really that kind of became the central approach to how we looked at the rest of the analysis. We started to think more systematically about what might be driving some of this lack of visibility, because in order to actually understand what's happening with our population and how to better our outcomes, we needed to be able to find them first in the postpartum period. So we scratched this kind of initial approach. And this led us to kind of focus on three new domains. First, we wanted to look at the ability to determine MOUD continuation at all. Second, we wanted to look at the overall postpartum data visibility, whether patients are actually captured in any way that providers are able to see consistently and able to access and interpret. And then third, what are clinical touch points looking like? Are we just missing them because we're not seeing them in the EHR, or are they actually not necessarily happening in that first year postpartum? Um, and so we kind of shifted in some of our preliminary analysis. We started to see a pretty stark difference between the integrated and separate care models in terms of this visibility. And so rather than continuing to focus just on discontinuation, we shifted the analysis to compare these two models of care, the integrated versus separate prenatal care models, to better understand if structure itself might help to see what is ultimately happening and how we can support our postpartum patients. So in terms of primary outcomes that we were looking at, the first was the ability to determine continuation of MOUD at the first year postpartum via the electronic health record. In terms of deliveries at UVMMC, using EPIC as kind of the main charting mechanism for deliveries, that was the system we wanted to see if we could follow patients after their delivery in that same system. We also wanted to look at postpartum healthcare touchpoints, including the number and types of visits, and then a number of secondary outcomes in terms of just antepartum factors as our secondary outcomes. So the same cohort, like I had mentioned before, 175 deliveries. The majority of our patients were receiving care in separate models, which if you remember from that timeline that I showed at the beginning, that's definitely a big change throughout the past years. Before, a lot of patients were getting their care in the integrated care model where the obstetrician or family med provider who was providing their prenatal care was also providing their medication for opioid use disorder, but definitely a big shift, which makes sense as we've been able to expand access through all of our spokes and really provide good community care for our patients. So 77% were receiving separate care. The majority of patients were actually already on MOUD prior to pregnancy, and over 90% continued that through the time of their delivery. There was a really high antepartum engagement in both groups, slightly more average number of visits, 9.1 versus 7.4 in the integrated care group, but really kind of showing or highlighting that the issue is not necessarily the initial engagement for patients, but really kind of more so what happens after delivery, where we see a big drop off. So when we look up some of the follow-up patterns, like I mentioned, we see this big drop off. Looking at the EHR and touch points for patients, a substantial portion of patients had really limited or no documented healthcare engagement in the first year postpartum. It's a little bit small in the text, but 43% of patients didn't have anything documented in EPIC in the first year postpartum. Which is a huge gap, not just in care delivery, but also in our ability to see what's happening and monitor outcomes and intervene with patients when needed. The darker blue, the 24%, that's just ED visits. So that does not mean any sort of really continuity with their primary care provider or their obstetrician. That was just a touch point in the ED. 21% in the orange. That was just a single postpartum visit, which typically was done at the 6 weeks postpartum. And then the the greater than one follow-up essentially was any sort of touch point that was more than just one single obstetrician visit. We found that often that could mean a subspecialty visit, such as physical therapy for a musculoskeletal issue, maybe GI or ENT or ophtho for some kind of specialized issue, but very limited continuity in this first 12 months postpartum. Kind of summarizing all of this, so the MOUD status was captured in EPIC in only 51%, so just barely over half of all patients in the first year postpartum. Interestingly, from that graph that I showed, the number or types of visits within the healthcare system did not actually significantly impact the likelihood of us knowing their MOUD status. So whether or not they were seen didn't necessarily impact if we knew what was going on. But what we did see was that for the integrated care patients, there were significantly more likely to have MOUD status documented at 1 year postpartum. So 68% in the integrated group versus 46% in the separate group. So a big kind of thought of why this is happening is in the integrated care group, eventually those patients will not be receiving their MOUD through their obstetrician or the person that was providing them their prenatal care. And so ultimately there has to be some sort of transition point at some point. And so we're seeing much more documentation and touch points and kind of a better system in terms of facilitating that transition that was then subsequently documented in the EHR. So not necessarily were they receiving, better care or care that was more comprehensive or more continuation, especially, but more so we were just able to track what was going on. Whereas a lot of patients who were not in the integrated care model were often completely lost to any sort of follow-up, despite them most likely receiving very good care in the community setting. We just didn't really know what happened to them. So overall, the quantitative findings kind of highlight several key points. First, the postpartum care trajectories for patients with opioid use disorder often become invisible to the healthcare system. Based on the graph I showed earlier, only 1 in 4 patients on medication for opioid use disorder had no documented healthcare visits the entire first year postpartum. And despite some of this super high antepartum engagement, it really drops off postpartum, especially in terms of continuity when there's really a limited transition period documented. And then, as I noted, the integrated care model does increase data visibility, most likely because of those documentations of care transitions and the need for some sort of kind of transition out of the integrated setting. So at this point, this data kind of showed that there were clear gaps in being able to identify what was going on with our patients. And so Jasmine was able to work with the qualitative side of the study to kind of better understand some of the clinical and logistical and system level factors that contribute to some of these patterns. So I'll go ahead and turn it over to her for that part.
Okay, thank you, Presley. So now we're going to review the qualitative portion of the study. And so the qualitative portion of the study has the research question, which Presley referred to earlier, but what clinical factors contribute to gaps in perinatal substance use disorder care? And one caveat before beginning this portion of the presentation is that this study is currently in progress with active recruitment of interviewed participants. And so what we're presenting today are preliminary findings from an incomplete data set. And so analysis is ongoing, and these are emerging insights. In terms of the qualitative data collection, we used a survey which consisted of 9 domains, starting with demographic information, and then we discussed medication-assisted treatment, hospital policies and practices, system-level barriers, handoff practices, perinatal mental health and social work coordination, and referral to recovery centers and harm reduction strategies. And there's a QR code in the bottom right-hand corner of the screen for the anonymous survey if you'd like to look at the questions in more in depth. And then this is also an option for participants who would like to complete the survey anonymously. This has been reserved for providers who have lived experience and would like more of an anonymous form of participation, but we've definitely more highlighted focus group interviews and one-on-one interviews of providers. In terms of research study participant recruitment and where we are right now, we definitely are still recruiting providers to participate in an interview. We have 15 providers that have participated, and we're 32.6% of the way towards our goal in terms of provider recruitment. One big gap that you can see with the star on the screen is emergency medicine providers. We have not interviewed any emergency medicine providers yet. And so if you're an emergency medicine provider on the screen, we'd love to hear from you. And so in the top left-hand corner is the information sheet to learn more about the study. And then in the lower left-hand corner is a QR code to sign up for a one-on-one or focus group interview. In terms of our research study participation by county, this is also an area of improvement that we're hoping to have with more providers signing up. And again, the QR code on the bottom right-hand side is there if you'd like to participate, and if you happen to not be in Chittenden County, because you can see that a majority of providers are coming from Chittenden County right now that have participated in the study. In terms of the training portion or the research study participant training, in terms of this is a discussion that we had in terms of formal training for perinatal substance use disorder care. And so providers reported limited formal standardized training in the care of perinatal patients with substance use disorder. And as you can see in the graph, over half of the participants, 53.8%, reported about 20 hours or greater in this area. And training was most commonly obtained through icons and PQC webinars like today, rather than a formal certification or a structured program. And overall pathways were described as informal and variable across providers. And findings may reflect just a self-selected group of highly engaged providers. I think 20 hours or greater is pretty substantial, but many of whom described independently seeking additional resources such as evidence-based literature, memoirs, to support patient care. And then on the slide as well, you can see on the right side, there are some highlighted excerpts from the interviews where the first provider is talking about lectures and the second provider is talking about, across all providers, there's the DEA certification, but unsure if other providers are seeking out additional training for perinatal patients with substance use disorder beyond this. And then the last provider is talking about pursuing numerous trainings over the years with webinars and conferences. In terms of lived experience with substance use disorder, 66.7% of providers reported lived experience with substance use disorder, and all felt it enhanced patient care. lived experience is defined as providers with lived experience of substance use disorder themselves or with a family member or a close friend. And providers identified three key positive themes of lived experience: enhanced empathy, compassion, and humanization of perinatal patients with substance use disorder. Lived experience was also associated with minimal perceived drawbacks, and this improved the understanding of barriers um, and also improved understanding of barriers to self-care and caregiving for this patient population. In terms of the three themes that were identified for lived experience, here are some excerpts from the qualitative portion. Compassion was listed, and then also empathy. I want to draw your attention to provider number 3. So this provider says lived experience with family members or friends helps in terms of developing empathy for what other people in their lives are going through. You often see the pain of the person. And then in terms of the last theme, humanize, provider number 4 notes that perinatal patients with substance use disorder may not look good on paper or in the electronic health records, but their lived experience allows them to have a nuanced perspective of this person with a family. This is a person that came out of somebody's uterus, and this is, someone that you're able to humanize. During the interviews, we also discussed clinical strategies and really thinking about what providers felt were effective care as well as ineffective care. And so first we'll go over the effective care strategies that were mentioned by providers. So the first would be robust social support systems. Social workers and case managers are essential team members. This was highlighted by unanimously by all providers. And also having a social worker or case manager who is a dedicated perinatal team role really enhances care coordination. And then also addressing stigma and bias with compassion and empathy. So having intentional efforts to reduce bias and emphasis on compassionate, not judgmental care. And then also trust and relationship building. So strong provider and patient relationships are foundational, and having identified gaps, so need for improved continuity of care and extended follow-up up to 1 year postpartum is seen as highly effective. And then also integrated group-based care models. So group therapies to foster connection and recovery support, opportunities for perinatal patients with substance use disorder leadership within care settings, and the OB potentially as the MAT prescriber in the perinatal period, or strong communication with the MAT prescriber. And then also specialized perinatal recovery referrals. So a strong endorsement of perinatal specific programs such as LUND and tailored services improve engagement and outcomes. And so one provider expert that I just want to highlight here is that a provider really endorsed LUND by stating that they found success in referring patients to LUND shelter. It's a great place for an unhoused person. I think it's allowed patients to do well, receiving all of the things, all the resources they need in one place. So what doesn't work? Something that unanimously was mentioned was judgment. There's also abstinence and then lack of care coordination and disconnected care systems. So in terms of judgment and bias, providers felt that this eroded trust and discouraged patient engagement. In terms of abstinence-only approaches, many providers felt this was misaligned with evidence-based perinatal substance use disorder care and may increase risk of disengagement and relapse. There's also lack of care coordination, patients expected to navigate complex systems independently, and absence of perinatal specific social worker or case manager limits access to needed supports. And so a couple things I want to point out in terms of the excerpts here. Abstinence, the provider notes telling patients to abstain is not supportive because it's not as simple as that. And then lack of care coordination for provider 3 continued by stating, asking patients to connect themselves to resources rather than us providing some of those, at least giving contact information. Sometimes part of the barriers to receiving these resources is just knowing where to find them. And so then the provider further notes, I do believe that's part of our responsibility to provide patients with resources. We also discussed the role of the peer recovery coach. And in terms of the interviews so far, it seems that peer recovery coaches are underutilized. 58% of providers are uncertain or do not include peer recovery coaches in their current care of perinatal patients with substance use disorder. So there seems to be limited awareness and access. Many providers are unsure how to access peer recovery coaches. There's a perception that availability is limited um, and only primarily in emergency department settings. There's inconsistent availability across sites, and access varies by clinic. They're not universally embedded. And then patient uptake varies as well. So peer recovery coaches might be offered, but some patients decline. And then there's also knowledge gaps about the role, scope, and integration into perinatal care. I think another positive portion of the study is how providers feel that mental health is being addressed for perinatal patients in the state of Vermont. Uh, Overall, providers felt that there was a high co-occurrence of mental health and substance use disorder. Unanimously, 100% of providers reported regularly encountering perinatal patients with co-occurring mental health and substance use disorder, and they endorsed a strong collaboration. 90.9% of providers felt like they were able to coordinate care directly with psychiatry or psychology. And a key strength would be robust mental health provider network. And then there was frequent highlights of Dr. Saragu's contributions. In terms of the identified challenge for mental health that a good number of providers mentioned would be just additional mental health appointments, uh, which increase the perinatal patient burden within an already high-touch care model. Social determinants of health were also discussed, and transportation was listed as a key barrier. And this was most cited, but then also housing insecurity and food insecurity. And so the current limitations are with that Medicaid transport exists, but it requires advanced scheduling and offers limited flexibility. There's also patient burden. And so many providers would mention that perinatal patients with substance use disorder often have executive functioning challenges, and this makes coordinating rides in advance difficult. There's also a care impact. So transportation barriers can shorten visits or limit access to care. Access gaps, there's vouchers and alternative transport supports, but they're inconsistently available. And then also care complexity. So patients must travel to multiple providers, such as their MAT prescriber, their OB, pediatrics in the postpartum period, community services. And so that can add challenges as well. And then postpartum MAT challenge. So ongoing transportation needs to maintain MAT while visiting hospitalized infants, such as just for that initial eat, sleep, console protocol. And then there's also, we discussed kind of reframing relapse and just a general rethinking of the system's perspective. And so our reframing was really that providers view relapse or abrupt MAT discontinuation not as a moral failing, but as a signal of unmet needs. So return to use often reflects underlying stressors such as transportation barriers, housing or food insecurity, or untreated mental health conditions. And one action point here is to address co-occurring social determinants of health alongside substance use disorder treatment with comprehensive reassessment during periods of high relapse risk or recent return to use. We also talked about screening for perinatal substance use disorder and the universal screening tool. And so if you look to the left side of the screen, approximately 60% of providers note always participating in a universal perinatal substance use disorder screen, with a majority of providers screening at the first perinatal appointment without any subsequent screening. From the sample of providers interviewed, there is not one screening tool which is being used consistently for universal perinatal substance use disorder screening. And providers note that a majority, 75%, incorporates polysubstance use screening into their universal screening practice. If we go to the right side of the screen, all providers interviewed did not know of a formalized protocol in place for a positive perinatal substance use disorder screen. In the survey or in the interviews, we also talked about care coordination and handoff gaps in perinatal substance use disorder care. And so on the left side of the screen, we were able to I was able to graph the frequency of the handoffs. So over half of the providers, 54.6% report handoffs occurring rarely less than once a month or only occasionally 1 to 3 times a month. And then in terms of communication is primarily occurring via chart review. So most handoffs rely on chart review alone, just i.e. reviewing notes in the chart, and direct communication calls or messages are rare, and this is limiting continuity of care. There's also inconsistent or incomplete documentation. So chart information is variable and often insufficient, especially outside of OBGYN, and labor and delivery documentation frequently lacks details for ongoing substance use disorder care. There's unclear or missing information regarding the use of the universal screening tools and whether the universal screening for substance use disorder was completed, and lack of standardized proactive handoffs are creating critical gaps in perinatal substance use disorder care continuity, highlighting an opportunity for structured communication protocols. In terms of diving deeper into the key information gaps in handoffs, providers noted that when an OB provider is handing off to an inpatient psychiatry provider, some information that might want to be providers would like to be highlighted would be MAT parameters, dose adjustments, clear guidance for titration or tapering during pregnancy, and perinatal substance use disorder specific vital sign considerations. And then for OBs thinking about what might be helpful when receiving a patient from a primary care provider, the things that were highlighted were active substance use history, MAT details such as the current dose, the prescriber, adherence, and then also social context. What are the patient's strengths? What are recent successes in their recovery journey? And support systems and gaps in care. There's also an overarching theme here about the unique vulnerability of perinatal patients with substance use disorder. Many providers mention that this is a small population, but we know that this patient population is disproportionately affected by a high maternal risk. And so perinatal patients with substance use disorder are navigating a dual stigma, the criminalization of substance use disorder, and also the scrutiny of potential child maltreatment. And then identity integration is critical. So perinatal patients with substance use disorder are both parents and individuals with substance use disorder, and these identities can coexist with support. Limited perinatal specific resources as well. So few treatment options are specific for perinatal patients. Lund was definitely again highlighted as one of these great resources in our state, but others, it would be great to have others. And then also emerging progress, so family-centered programs at Turning Point. Turning Point now allows children to join their parents in recovery at programming. And then also unclear mandatory reporting practices. So providers report lack of clarity on when to contact Department of Children and Families or DCF, and an opportunity for guidance and education. So the key takeaway would just be that stigma and limited resources and unclear reporting pathways create gaps, highlighting consideration for perinatal specific substance use disorder integrated care and provider guidance. And overall, the clinical factors contributing to gaps in perinatal substance use disorder care would be first, training and clinical preparedness, limited formal training despite a high-risk population, a mismatch between clinical complexity and existing guidelines, workforce and care model gaps, so need to integrate providers with lived experience, such as peer recovery coaches, an opportunity to build patient-to-peer leadership pathways, also addressing stigma and provider bias, ongoing need for reflection and stigma reduction, and support integration of substance use disorder and parenthood identities, unmet mental health and social determinants of health needs, so frequently co-occurring with crisis or relapse. Social determinants of health are often unaddressed, and lack of proactive integrated screening and response systems. And then also care delivery and communication. So limited continuity across perinatal to 12 months postpartum, and gaps in universal screening implementation, positive screen response protocols, and then also standardized handoffs and care coordination. So overall, the gaps are reflecting system level limitations in training, integration, and coordination, and highlight a need for standardized longitudinal sigma-informed care models. As I mentioned at the beginning of the presentation, we are still actively recruiting for our study. And so if you're a provider who cares for perinatal patients with substance use disorder, we'd love to hear from you and hear your perspectives. So if you could use the QR code to look at the information sheet, and then also the QR code to sign up. And there's a couple upcoming webinars that I think are really great to mention as well, specifically around the discussion of Department of Children and Families, and really how to support the unmet social determinants of health needs for this patient population. And so just wanted to highlight the two upcoming webinars in June as well here.
And so from here, we kind of gleaned a lot of information in a few different capacities. We started kind of as an effort to really understand treatment discontinuation and how we can better support our patients, especially in the postpartum transition. But we really found kind of twofold that the system really loses sight of these patients, and kind of especially when they're in the most need of our continuity. As Jasmine had said before, this isn't a patient level failure, but rather a lot of system issues that are at play. And so we really wanted to kind of take some time to, at the end of this, as an opportunity for discussion. These are kind of the main areas that we were able to glean as kind of important opportunities for improvement. I think these are all systems level questions and big things to focus on, but none of them really have simple answers, and will be kind of ongoing work, but kind of identifying these as some of the key areas. And if anyone has any particular questions or things they wanted to chat about, we definitely wanted to leave time to be able to answer those.
And Presley and Sam, would it be helpful to facilitate discussion to stop sharing at this point? I think the slides will be shared at the end.
Yes, we can stop
Okay.
sharing.
Okay, thank you.
And I also wanted to note that put some of the registration links for the future webinars that Jasmine had mentioned. I'm also going to be adding a few other resources that are relevant to this larger conversation.
Oh yes, and our final slide, which we didn't show there, but it will be in the PowerPoint that's sent out. We listed a bunch of resources as well, a variety of different like online and conference-based resources.
Yeah, and I think just to highlight some of the resources, because they were one would just be the Vermont Consultation Psychiatry Access Program, or CPAP. Great way to get in touch with a mental health provider for a perinatal patient. The Turning Point Center to get in touch with a peer recovery coach. And then also when thinking about kind of this idea of formal training, there's an upcoming course in San Diego for an upcoming conference. And so you can register for the course and either participate in the recording or in person. And then there's also great resources, as many providers mentioned, within the V-CHIP umbrella, specifically with PQC and ICONS. And so that website is there. And then also the Alliance in Maternal Health, or AIM. All right, I'll stop sharing again.
It does look like we have a comment in the over here of from Mary Lou that I am not aware of what types of peer support programs are available in MAT programs. Would be great to have resources list. And does anybody on this call are aware of a list of that already exists?
This is Jennifer down here at CVMC, and I had written down further down that I can touch base with Mary Lou about what we have in Central Vermont. Our Turning Point Center in Barrie has many, many resources. They're in our ED, but they can also visit to our labor and delivery unit as needed if they haven't gotten connected prenatally. Um, the Turning Point Center down here also pairs with our Parent Child Center, and they're offering a parent support group, and that is also expanding. Our local Good Beginnings organization also is pairing with the recovery coaches. So the Good Beginnings organization has postpartum angels who are volunteers who can visit with people postpartum, sort of as a mentor and support. And they are also pairing, or they're training recovery coaches to be postpartum angels also to be able to pair um, a postpartum angel with a newly postpartum person who might have substance use either in recovery or other concerns. So we have a pretty good growing matrix of supports.
That's awesome. Hi, Jennifer.
It looks like Rachel's asking if providers have access to the social determinants of health information that's collected on nursing by nursing while patients are postpartum at UVMMC. Um, Yes, Rachel, I think we do. At least in my experience, I have seen that. And I've also looked through, I know social work also does a pretty extensive collection history during the postpartum period. Um, I personally have seen it before. I don't know how often that is accessed as like a key place for that. I think often when there are issues that are brought up, the postpartum nursing team has been awesome in conveying those to the provider team, but I don't know how often it's readily like referred back to, especially since it is in a nice like living document in the EHR.
Jennifer, I see your hand. Feel free to.
Hi, I just wanted to say that I think that Epic, I don't know how many hospitals within the CV or the UVM health system are actively using the My Pregnancy Journey, which is newer, and that also has some major checklists for both the patients as well as for providers. And our team down here is newly using it, and the supposed to be what's supposed to happen is like you reported on a social determinants of health screening happening around the IVAP initial visits, including the Edinburgh, as well as other social determinants of health screenings. There is the only substance use piece of it. It does not talk about specifically cannabis. I think other substances are listed in there. It's not as robust as it really needs to be. So in any case, that should be all going out. So people should have access to that in the My Pregnancy Journey, checklists. But I think it's all newly being used. So I don't quite know the standardization across the hospital. Can I also say, as far as screenings, we have been talking here. We wouldn't be able to initiate anything because it really has to come from UVM Health, but the 4Ps is a screening that we would love to be using here. We're not initiating it by handing it out on paper for patients just because they get so many other screenings, and we're trying to have other follow-up and conversation. But I think if the powers that be wanted to have a screening in the electronic medical record, something like the 4Ps would probably be the best starting point. It's just not in there.
Oh, it looks like Michelle just noted that the 5Ps is on its way. So that's exciting. And that the 5Ps are also being used at NVRH, but not in Epic.
Any other thoughts or reflections from the group?
All right, then I'm going to add the evaluation for today into the chat. So you all have that. And also, as people are collecting some ideas for continued questions, know that I have recorded this. So I will be sending out this recording as well as the slides and lots of all the resources that was mentioned today. So expect that within a week. Oh, so we do have an additional comment from Mary Lou. So that most of the responses in the study seem to be relevant to the Burlington area, which makes sense given your response percentages from Chittenden County.
Mhm. Yeah. Yeah, but we definitely would love to expand that and get more from both the retrospective from the chart review data, but then also from the survey aspect from a greater area. We focus just on UVMC, but would love to do a similar chart review for the network hospitals as well.
Yes, and since the qualitative portion is still going, I'm just putting the Calendly in the chat. If you're a provider who's not in Chittenden County, would love to hear your perspective.
Excellent. Thank you so much for being here. Thank you, Presley. Thank you, Jasmine, for this wonderful presentation. And if any of you come up with questions later, please send those our way and make sure you get your answer. All right. Thank you.
Thanks so much, everyone.
Thank you.